consultant of pediatric neurology at New Health called GLT here in Dubai. I think you come to Abu Dhabi.
In Dubai. Now in Dubai.
Well, he will talk to us about managing common child neurological disorder. Are you going to say that?
Okay? Yes. Okay. Good afternoon. I hope you are not as sleepy as me. Today we're going to talk about common pediatric neurology cases. You know, my first goal in this presentation is to entertain you. My second goal is also to entertain you, and my third goal is also to entertain you. And if you, by the end of the presentation, have one or two pieces of information, I'm very satisfied. Okay? That is my name. And this is my website. If you want to see the most photogenic face, you go to the website, you will see me there. And a lot of the time, guys, as physicians and as you know, doctor, we tend to forget how does our patient feel, or the patient we are treating is a human being with a lot of feelings, especially in the field of neurology and in the field of psychiatry. So I'm going to start with what we call a tissue time, touch of sadness, a wake-up call, if you want to say it like Mr. Yasser. That's an overview of where did I my training and where did I work. Currently, I am moving to Kids Heart Medical Center and DLCC, inshallah, within 1 or 2 months. And this is a poem, if you would say, by, can you play the music, please? With one of the patients who suffer from epilepsy, and he described what does he feel when he has the attack before we treat him, or before the patient was treated. This is to tell you how much we are important and how much the patient, when they come to us, they have a big hope in us. Okay, it's here again, the sinister sensation of an aura that I only know too well. Searching for a safe place to lay down. As I descend into my private hell, I shout out loud, it's happening again. It's beyond my control. Dropping down heavily, my head hits the floor. Feeling horrid, my mind and body is no longer in my control. Twitching, shaking, and staring into space, I black out. Arriving back to consciousness, all I can see are my pairs of shoes, horizontal on the floor. I began to apologize after what's just happened. I have nothing to lose. Standing up, leaving my pride and dignity back there on the ground, people began to walk away while some glance back around. No need to feel so embarrassed. I keep telling myself nothing wrong with my state of mental health. It's beyond my control. I can't stop it. And only it decides when I will suffer my next fit again. Anybody need tissue, guys? Okay. So that is how the patient, feel with seizure and with their disease. Now let's go for the month. Case number 1. I'm going to present clinical case scenario, and if I know your name, you are not, you're going to be asked, to give me your answer. Okay. Case number 1, and these cases are real cases I have seen, and I want to work with you guys to see how can we manage these cases and what is the best way to manage these cases. Okay. 9-year-old boy not known to have any medical disease, presented to the ER with sudden onset seizure with fever, lasted for 5 minutes. The patient is 9-year-old now. In the ER, he was post-ictal but easily arousable with deep pain stimuli, no focal findings. His vitals are all within normal limit, except his temperature 38.9. Physical exam respond to deep painful stimuli, no meningeal signs. Head CT was normal. Attempt to do spinal tap failed, and family refused further attempts. And the dad is a typical Jordanian, and I don't want to mess with this guy. So he refused. I respect what he wants, and we move for the next step. Your next step, guys, in management. Can you still hear me? Your next step in management? Okay, first, what are you going to do? Get baseline lab and try to tap them in AM. Obtain repeated CT with contrast, okay? Start hemorrhacin at a meningitic dose. Start rosifin, vancomycin at meningitic dose. Start rosifin, vanc, acyclovir plus dexamethasone. No need for spinal tap. It is febrile seizure with no meningeal signs, no focal finding. No need for spinal tap. It is seizure triggered by fever. Just observe. Right? Who would go for 5? 5 for 1, 5 for 2, 5 for 3. Who would go for?
7.
7. Excellent. Who would go for 7? Okay. Perfect. Excellent. Dr. Yasser, what do you want to go for? Because I'm really interested in your answer. 5? Okay. Perfect. And this is the real answer. Those who said, okay, let's go. Number 6, no need for spinal tap. It's febrile seizure with no meningic sign. This is absolutely not the case. Beyond 6-year-old, don't talk about febrile seizure. I get alert. I get lamental rash, okay? Second, 7, no need for spinal tap. It is seizure triggered by fever. Just observe. This is his first seizure with fever. He does not have a history of epilepsy. I would not risk it. Because if I miss this guy and he tend to have a meningitis or early case meningitis, you're going to be in a big trouble. Okay? So I would definitely go for 5. Be on the safe side. Okay? Now, second day they called me. I'm Jordanian. The guy is Jordanian, the dad. I sweet talk with him. I know how to talk with him, know the background. Okay? And we tapped the patient. And this is the spinal tap. White blood cells 150, protein 200, the glucose normal, RBC 100, grams still negative. If you are in my shoes, what would you choose next? Gentamicin and DC-rosifin based on these lab. DC antibiotic and keep acyclovir at this look more viral HSV meningitis. Add HSV PCR to CSF sample if it is not a ton. A lot of the time forget to do that, right? DC or antibiotic as a gram stain is negative. Lol. Add ganciclovir. If you are in my shoes, what would you choose? 3. Who? 3? Okay. Who would choose 3? Hands up. Hands up. Hands up. Yes, sir. 3. Okay. Who would choose a different answer? Perfect. So we will need to do HSV PCR because it's a hemorrhagic. There's blood in the CSF. Okay. It looked viral, and there's a blood, and this was not a bloody tap. Okay. So I would be on the safe side. Now. Second, additional investigation that might be helpful in this case is repeat spinal tap in 72 hours, repeat head CT with contrast, MRI of the brain, none of the above, all of the above. Mafia approach.
3. MRI.
I would say 3. 3. Excellent. Who would say none of the above? Who would do mafia approach? You're losing nothing, man.
Could I say something?
Mafia approach? Okay, perfect. Okay, so what would you see in that? So the MRI of the brain, I would say it might be helpful. Why MRI would be helpful in HSV encephalitis?
Might find anti-symptom encephalitis and focal lesion there.
Bingo. Excellent. Because you might see this thing. Look at the temporal lobe. It's heavily involved. So the HSV encephalitis has a high predilection for the temporal lobe. So MRI might be helpful, huh? Okay, and this is you see here, it's high T2 signal and flare T2 image, okay? Was it? Okay, sure. Now, another test that might be helpful, sorry, we were going too fast, EEG, nerve conduction study, EMG, throat culture, cardiac echo, upper GI series, follow up through, none of the above, all of the above, who cares? EEG. Perfect. Why we are going too fast? EEG. Are you pushing with that, brother? Okay. Okay. Okay, let's do one thing.
You're far away from the controller.
I'm far away. Okay. Now, EEG. Now, who said EEG?
You said
Yeah, that's not the question. What do you call this?
But you do
it is unifocal. It is unifocal
Uh-huh.
partial season.
Excellent. What do you call them? The is not allowed to answer. They call the PLIDs, periodic lateralized elliptiform discharges, and these discharges are not specific to HSV, but in the clinical context, it might be very helpful. And if you see that, you need to continue on the medication, okay? Now, 2 days later, HSV PCR was positive. Next step, treat for 21 days, repeat as CSF, HSV PCR, and chemotherapy. If it's still positive toward the end of the treatment, treat for 10 days, and ganciclovir 1 and 2, none of the above.
21 days.
21 days.
21 days. What did you say? 5. Okay. So the real answer is 1 and 2. You can treat for 21 days, but if you're in a rush, after 14 days minimum, you have to repeat the CSF. And if it is negative, you can safely stop the medication. But if it's positive, you have to continue until it becomes negative toward the 21 days. Okay? Perfect. Now, your most likely diagnosis is? That's a very simple question. Who? 3.
Number 3.
Anyone against number 3? Perfect. So number 3. Alright? Now, 7 days later, I got the call, Dr. Hamza, we forget to order acyclovir, and we know we can get it in the next few days. Your next step to treat this HSV encephalitis is foscarnet, Tamiflu, ganciclovir, foscarnet, and ganciclovir, repeat spinal tap, and if it's negative, stop the treatment. And remember, 7 days later.
Ganciclovir.
You do not stop the treatment.
Perfect. But what's your answer?
Ganciclovir.
Okay. So the real answer is? What is the other virus we treat ganciclovir with? CMV. Perfect. Okay, so it's 75. Now this is from up to date. There's a couple of what we call a couple of reference here and plus up to date. And the reason I put up to date because it is very easy. Anybody can access up to date. You don't have to give me a call at 2 a.m. in the morning. Open up to date and go for it. Okay. Now you always have to put in 3rd generation cephalosporin. Plus you have to add a vancomycin. Okay. At meningitic dose, very important, okay? And if you have a suspicion, please don't hesitate to put the patient on acyclovir. It's not going to kill him, but you can save the life of the kid. And this is from up to date 2015. Now, dexamethasone, it is very helpful. Some people say it's very helpful. It might decrease the inflammation, okay? It might decrease the hearing loss in the case of Haemophilus influenza, meningitis, okay? We'll give you credit for that because it causes inflammation. And a lot of people, they say, you know what, you can use it, but if it is later than 1 hour has elapsed since the first dose of antibiotic therapy, you might not use it, but you are not losing anything. Use it, okay? Lose it or lose it, okay? Now, herpes simplex encephalitis, very important. Although the outcome of HSV meningitis without encephalitis is usually excellent, even without antiviral therapy, we are talking about meningitis here, not encephalitis, not involvement of the brain itself. Acyclovir can be used to hasten recovery. Acyclovir is dosed as follows, and this is on up to date, okay? For neonatal 60 per kilo, divided every 8 hours, for minimum 20 days, 21. For CNS infection, 3 months to 1 year, to 11 years, 30 to 45, divided every 8 hours for a minimum of 14 to 21 days. Okay, so never ever treat less than 14. And for CNS infection, more than 12-year-old, 30 per kilo, divided every 8 hours for a minimum of 14 to 21 days. Okay, perfect. Yes, and Dr. Yasser like to do hydration for these kids, and I definitely support him.
Because the renal classification of crystals can be there if you don't hydrate the patient.
Absolutely. Thank you for that. Case number 2. Okay. 7-year-old boy presented to the ER with generalized chronic seizure that has been lasting for 10 minutes. Okay. family stated that he is known to have partial onset epilepsy, okay, and has been on Tegretol taking 203 times a day. Her brain MRI was normal and her EEG was consistent with focal epilepsy in the past. She is under the care of Dr. Al-Siyuf, which is me. Last weight is 30 kilo. Family already gave her rectal dexamethasone 10 milligram. Your next step in the ER while trying to obtain an IV line. And I tell you guys, in the ER when they have a seizure, it's a panic state. The doctor called me panicking. The patient, the mom is crying. The dad's upset, and everybody in the ER, is panicking. Always stay calm. Okay, please do me a favor. Okay. Now, bacamidazole 6 per kilo to abort the seizure, or 6 to abort the seizure. Rectal diazepam 10 is or 1 or 2, whatever is available. Number 3. Try to establish IV line and build the head with phosphatidone. Give Tegretol. Number 3. Anybody more than anything other than number 3. Okay. So the real, you want to stop the seizure. Next to is benzodiazepine. In the ER, even if you have rectal, buccal, whatever, you give it to them. Okay? Now, IV line is now available and patient is still seizing in the front of your eyes, and your child neurologist is on call. Unfortunately, he is not answering his phone. Okay? Now, you want to do with what? Load with phosphatidone 30 per kilo. Load with phenobarb 30 per kilo. Give the third dose of IV benzodiazepine, start IV midazolam.
Which one he was on?
Number 1.
Barry.
Number 1.
1?
Number 1.
He wasn't.
3? I can't live with that.
3.
Number 1. 1.
3.
1 for 1. 1 for 2. 1 for 3. 1. Okay. Perfect. So, load with phenol. Look at the dose. The 30 per kilo.
It's not correct.
Okay, refer please to my lecture about the therapeutic doses of anti-epileptic medication. When I load with 30, the kid is not dying. How did they decide that, 30, more than 30 level is toxic, less than 30 is toxic? This is something very interesting when I was preparing for my lecture. There's no time to explain that. So load with 30. Now we loaded with 30, and she is still seizing 10 minutes after. Next step is, I will give another 10 per kilo phosphatidone, start phenobarb 30 per kilo, give 20 per kilo of dibakine, go to general anesthesia, shift to PICU. Shift. One. I will go for 1. And sorry, you confused me. 2. So start phenobarb 30 per kilo. And it's okay, you can't start 30 per kilo. Don't panic. The kid is not gonna die. These toxicity guys, these medication toxicity, I work with one of my physicians, he would load 20 per kilo phenobarb, is not working 20 per kilo another phenobarb. We have patients, we keep their phenobarb level up to 80 or 90, but in the ICU.
One thing is, some issues they are very panicky. After 5 minutes, the patient is not responding, they go to other high dose, that's pretty
Okay. He's in the hospital. I hope you know how to handle that, right? Yes, but be ready. I know. Yeah, for me, as a child neurologist, I go for 30. Hefty dose. I go 20, but if not, give another 10. But if the pain is 5 minutes or more, go for 30. Don't worry, I'll give you warranty 5 years. Okay. Patient got 30 milligram per kilogram phenobarb and is still seizing 5 minutes after that. Your next step. Hopefully by that time I am involved. Load with another phenobarb 20 per kilo. Repeat another 10 per kilo of phosphatidone. Load with Kepra. Start midazolam infusion. Start general anesthesia. Yes. Who would go for Kepra? Lovely. Okay. Now. The right answer, start with the midazolam infusion. Barrier. You do not like that answer. 5, okay. I can live with that. Okay. If you have anesthesiologist around the corner, you can do that. But you're not going to have that 2 a.m. in the morning. Okay. So I will start with the midazolam. Okay. And the reason I go through these cases, because even though guys, you open Hertling, you open every single reference, PubMed, up to date, they will tell you 1, 2, 3. but I still get every time, and wallahi, I have been in a situation where the whole ER is panicking, even the COO of the hospital calling me, panicking. For kid what? Post-ectomy. I'm stuck on the highway 1 hour, okay? And by the end of the month, I was not even paid for that, okay? Okay, now, patient stopped seizing while intubated and on ventilator. Finally, Dr. Baria, was able to, control the patient. She put him under control, and the patient is now in the ICU on ventilator. What do you want to do? Check tegretol, phosphonitol, and phenobarb level. Continue tegretol, phosphonitol, and phenobarb. Obtain CBC, CMB, LFT, consider spinal tap, and hook to EEG. Obtain brain imaging once stable, all of the above, none of the above. 5? Who would go for 5? Perfect. I would go for 5 also. You know what? It's very important. Don't forget to maintain the medication the patient is taking while he's in the ICU. Because, remember, phosphonitol and phenobarb can be very helpful, okay? And remember, guys, always seizure come at you fast. Seizure knock you right away stat. Seizure is not your friend. Seizure is your enemy to the end. Keep it in your mind, okay? Don't mess with Texas or with seizure. Now, if you go to up to date, what I would do, it is straightforward. Here, 0 to 5 minutes, benzodiazepine first dose. 5 to 10 minutes, benzodiazepine second dose. 10 to 5, 15 minutes, 20 per kilo. You can argue with me, I'll still put them in 30. Okay? 15 to 30, you can do that, or you do, the phenobarb, or you can use, Debakine. There's a good study, and Keppra. There's no study to prove that Keppra is helpful. I have never ever used Keppra in status epilepticus and worked except in one case. And I think the patient would have stopped spontaneously. I promise you, Dr. Yasser, from the bottom of my heart. Okay? Now, that's, a diagram. This is just, read and enjoy. Diagram, what you can do with this patient. It's the same thing. Benzodiazepine, second dose benzodiazepine. If you don't have phosphonitol IV line, third dose benzodiazepine, but ready to keep his breathing. Phosphonitol, phenobarb, then infusion midazolam. Don't waste more time. I have been calling kids season 1 hour in the ER, and by the time I reach there, they are still giving benzodiazepine. And he has an IV line. Why don't you follow the protocol? Benzodiazepine, phosphonitol, phenobarbital. ABC.
This child already on phenobarbital, so after phenytoin, you will give phenobarbital?
Phenobarbital has a linear kinetics, so don't worry. But be ready for the suppression of the respiratory suppression. Thank you. And this is, what you can go further. Now, key concept. The formal definition of SE status epilepticus more than 30 minutes is not practical. If the patient sees in more than 5 minutes, get ready to treat him as status epilepticus. Throw everything on him, even the kitchen sink. You can do that, okay? Early seizure management, including, to check, the baselines. First line therapy is benzodiazepines, first dose, second dose. And if these fail, you go to phosphonitol, phenytoin, and this give you the doses, okay? But for refractory, midazolam is very safe. You can give it IV infusion. Don't worry, it would not suppress the breathing very much, okay? And they will give you the dosing here, and EEG should be considered as the patient is under this medication. I have one fatal mistake. They give the patient, paralytic, and the patient is paralyzed, and his brain is seizing until it gets toasted. So if you give him a paralytic, don't feel very happy because he might not be seizing because he's paralyzed, okay? And his brain being toasted, and we have patient dying because of that, okay? Perfect. Next. Now, what is this?
Amphitheater.
You know this slide. You're not allowed to talk. Colosseum. Okay. And what they used to do, they used to have people fight here until death, huh? Predators, they call them, or predators, man against man, man against lion, lion against lion.
Gladiators, not gladiators.
Gladiators. I'm just practicing memory. Perfect, excellent. Now, after they die, they tend to drag them through these. They are bleeding, they drag them away. And the people collect the blood on their way out. Anybody know why do they call it Donald except you?
Epilepsy.
Ah, okay. So they used him as a drug of choice for epilepsy, or what they used to call falling sickness. Huh? So we don't use that in my clinic, so don't be funny. Send me patients. Okay. Now, Salem witch trial. People in the 16th century who had epilepsy, they were accused of doing witchcrafting or black magic, and they would take them, and people were burned to death. And this is real. This was in America. Burned to death. People were stoned, beheaded, or stoned or killed because this is called witchcrafting. Okay, even though they were seasoned. Okay. And there was no pediatric ones at their time. I agree with you. Okay. Now, if you see an adolescent or you see like a geriatric patient every now and then, and this patient has epilepsy, you might as well document to tell him don't drive until you are 6 months seizure free. Do me a favor. Do yourself a favor and do the pedestrian a favor. This is a lady, and this is caught in tape. Real. She's driving a Mercedes in the States, so she's a high class, and this poor guy is walking across the street. Okay? All of a sudden, he's flying across the air. His bag is also flying. These are panicking. And this lady, look at her. I feel good, huh? She's not even paying attention.
He was not using zebra crossing when he crossed the middle of the road. He was not using the zebra crossing.
No, he was ministerial task. Let's not play like a lawyer thing. Look here, they are also crossing, okay? And this lady stopped, and this guy is already stopped. In the picture, everything is, static, huh? And this guy is flying, and if you look at this patient has complex partial epilepsy, not well controlled, and she drove across the guy and threw him in the air as if nothing happened. And if the neuron did not say that don't to drive until you are 6 months seizure free, most of the states, they will be in trouble. Okay? Now, this is the real case. I got called on Saudi. How much time do you have? 5 minutes? Okay. This patient is a 5-year-oold girl. I woke up in AM with inability to stand. She has been otherwise healthy with no recent infection. She has been crying and not herself. And mother brought her to the ER. She was refusing to stand up when her legs, deep tendon reflexes were normal. She kicked with her legs, and her exam otherwise is normal. Your first step in the evaluation is CBK, spinal tap, urine tox, X-ray, CT scan, all of the above. And this is what was done basically. I'm telling you what was done for this patient, okay? And not necessarily what has been done. So they did spinal tap on this patient, okay? And they did also the CBK, chest X-ray, head CT, everything came back normal in here. But she's still unwilling to stand up. And when I was examining her, she would look at me like this. I tell this patient does not look right. The way she looked at me does not look right. Okay? What does mean does not look right? She is encephalopathic. Okay? She is not interactive. So your next step is MRI of the brain. Perfect. So I told them to go ahead and do MRI of the brain. Even though the presentation was like, everybody was talking ataxia, this patient is, she has pain in her legs. I said, there's something wrong with her brain. And we did the brain of the MRI. And the MRI of the brain came back like this. What's your spot and only diagnosis? When you look at this MRI in this patient who is encephalopathic, not cooperative, not willing to interact with you. Okay. Cerebellar ataxia, transverse myelitis, ADEM or GBS. And you have the arrow there. ADEM, so she has acute disseminating encephalomyelitis. The key point, trust your examiner. When you see somebody, kids not looking at you, not interactive, go to the control center, okay? Right? To the brain. Now, treatment?
Steroid.
Pulse steroid high dose, okay? That's the typical treatment. And this is, just to tell you that methylprednisolone high dose is very helpful. It helps to speed the recovery of the patient, okay? IVIG may be used if the corticosteroid is not helpful, or if the patient, had side effect to corticosteroid, you can give her IVIG. Huh? Straightforward, right? Now, I'm not going to go further. As you know, guys, this is the fourth case. I think we don't have time for that. I call it now the poetry time. This is a poem I made. Probably people who attended my lecture before heard my poem. I call it "I Love Neurology." When I go through this poem, I want you to rest assured that there is, a medical and neurological information in this poem. Okay? So I say I love neurology, love it to death. Without neurology, would not have a breath. Without my neurons, I will be deaf. I will be confused, I will be stiff. Without them, I will have a useless nose. I will not be able to smell even a rose. Without my neurons, I can't breathe. I will be blind, I will not see. Without neurons, I lose my mind. I'll be rude, crazy, no longer kind. My thalami are my Wi-Fi. Without thalami, no ideas apply. Frontal lobe, keep my home. Without the lobes, I see a dark globe. Cerebral eye, hit my gate. Without the eye, I walk but never straight. Ataxia. My cords keep me adored. Without a cord, never on the road. Facial nerves help me blink. Without a blink, I couldn't have a wink. Amygdala keep my fear. Without the fear, I love the ear. The ear is the lion voice. Please do me a favor, leave me alone. Don't stress me. I need healthy neurons. Please help me save my neurons. Please give me stat value on the alone. And if you look at this one, for example, here, Klippel-Busse syndrome, if you hit the amygdala, paraplegia, if you hit the cord, ataxia, if you have cerebral injury, psychosis, if you lose your neuron, and the frontal lobe injury causes severe depression. That's why we have this one. And the sleep spindles are thought to be formed in the thalami. So if you don't sleep well at night, you will be dumb in the morning, and the idea will not pick or fly. Questions? You want to do a combined session question? You can do that? Okay. Thank you very much, guys.
Now, you know how much I worked to recruit you to